Hello everyone. So today's lecture we will discuss about the disorders of absorption. Whatever food we take has to be properly absorbed in our body. And what if it is not absorbed properly? It will lead to malabsorption. Yes, and the symptoms of malabsorption are very vague. So you may be thinking that the malabsorption patient will present to us with diarrhea, steatorrhea, flatulence, and whatnot, vomiting and whatnot, gaseous distension of the abdomen and whatnot. But let me tell you, starting from the central nervous system, sometimes the malabsorption patient may present to you with encephalitis. Patient may present to you with dementia. Yes, the Whipple's disease patient may present to you with encephalitis and dementia. Patient may present to you with pericarditis and cardiac manifestation, the same Whipple's disease patient. And sometimes the patient may present to you with metabolic bone disease, osteoporosis in the patient of celiac disease because of malabsorption of vitamins, malabsorption of iron. The patient may present to you with osteoporosis, fracture. The patient may present to you with iron deficiency anemia. So as a doctor, you have to identify all these vague symptoms and come to a conclusion and say that this is all because of malabsorption. So the symptoms is not only related to gastrointestinal tract in the patient of malabsorption, but the symptoms can be multisystemic, and you have to clinch the diagnosis of malabsorption, whether it is a celiac disease, whether it is a Whipple's disease, whether it is some other thing, whether it is a protein losing enteropathy. So as a doctor, you have to clinch the symptoms and come to a diagnosis in case of malabsorption. So not only one pathology, the gastrointestinal pathology of malabsorption will present with various systemic involvement, various symptoms, but other systemic involvement can also be present. In celiac disease, you may also get transaminitis. So not only understanding the symptoms, but understanding how to interpret the lab report, we will discuss in this lecture and make you very crystal clear about disorders of the absorption, how the absorption or the disorder of the absorption leads to various clinical manifestation and various abnormalities in the lab report, and how to treat all these malabsorption syndromes or symptoms we will discuss in this lecture. So look at this. So you have to know that the nutrient processing in our body or nutrient processing in our gastrointestinal system basically occurs in a three phase. The nutrient processing, whatever food we take, contain lipids, contain protein, contain carbohydrates, and or vitamins and minerals. So the nutrient processing, or how these nutrients are absorbed from the gastrointestinal system, we can describe it into three phases. And based on the pathophysiology of this three phase, all the disorders of the malabsorption can be classified. So first is the luminal or digestive phase. Whatever food we take mixes with the gastric and the lingual lipase, the gastric pepsins, the pancreatic pepsins, the pancreatic enzyme, and the hepatic bile duct. So the food we take mixes with the gastric juice, mixes with the pancreatic juice, mixes with the hepatic bile duct secretions or the bile salts, and the mixing occur, that is the luminal digestive phase. So if you think that if there is any problem in any of this, let's suppose there is problem in the pancreas, pancreatic enzymes are not being secreted in the duodenum, will the patient able to digest fat? No, because of absence of pancreatic lipase, the patient will not be able to digest fat, and the patient will have steatorrhea. Steatorrhea, that is the fat in the stool. We will describe what is steatorrhea and what is the definition of the steatorrhea. But if the patient is having pancreatic insufficiency, either because of chronic pancreatitis, either because of pancreatic cancer, either because of cystic fibrosis. The secretions are not able to come into the duodenum, so the patient will have steatorrhea. The fat digestion will not occur, protein digestion will not occur. Similarly, if the patient is having hepatic dysfunction, the patient is having primary sclerosing cholangitis, primary biliary cholangitis, then also the patient, the bile juice does not enter the duodenum, and the patient will again have fat malabsorption. As you know that the bile helps in absorption of the fat by forming the micelles, but the patient will not have digestion of the fat because of hepatic dysfunction or anywhere dysfunction in the common bile duct, either because of primary sclerosing cholangitis. If the patient bile salts are not produced because of chronic liver disease, then also the patient may have fat malabsorption. So remember the first pathophysiology, the luminal digestive phase. The digestion occurring because of with the help of the pancreas, digestion occurring with the help of the liver secreting the bile salt, digestion occurring because of the stomach secreting the gastric juice or the gastric pepsin. So any problem will lead to indigestion, or it will lead to problem in the absorption, because as there is no digestion, there is no absorption. So the patient will have steatorrhea in case of pancreatic and hepatic dysfunction. The second problem is the mucosal absorptive phase. What if the digestion is proper, the enzymes are present, the liver enzymes, the pancreatic enzymes are present, the bile salts are present, the gastric juice is present, but there is problem in the interface, that is the wall of the gastrointestinal tract, the mucosa, submucosa of the gastrointestinal tract. What will happen in such case? The patient will have problem in the absorptive phase or the mucosal absorptive phase. Let's say the patient is having celiac disease, there is problem in the mucosa or the layer of the gastrointestinal tract, it is not absorbed, the nutrients are not absorbed. We will discuss what is celiac disease and what causes celiac disease, but celiac disease is a classical example where the mucosal absorptive phase, there is problem in this mucosal absorptive phase, because the mucosa contain the brass borders. The mucosa contain the brass border, and there are enzymes in the brass border, the disaccharide, the peptidase, which the further dissolve the disaccharide into monosaccharide, and the peptidase will dissolve the peptide into amino acid, and there is absorption. But if there is problem in this mucosal phase like that of celiac disease, the patient will not able to absorb nutrient from the gastrointestinal tract and will lead to malabsorption in this patient. The phase 3 of nutrient processing is post-mucosal delivery phase. Whatever nutrient which is absorbed from the mucosa will reach the enterocyte, the cells of the gastrointestinal tract. And in the brass border enterocyte, this nutrient, whatever reaching the brass border enterocyte, will be processed. Fat will form chylomicron. So the fat which is absorbed by the micelle formation will form chylomicron, and this nutrient will enter the lymphatics and get absorbed in the systemic circulation, or it will enter the portal circulation and get absorbed in the systemic circulation. So there are two ways from the gastrointestinal tract how the nutrients are absorbed. It is absorbed either via the lymphatic channel or via the portal circulation, which will reach the liver. So what pathology can impair this post mucosal delivery phase? We have seen that the luminal digestive phase can be impaired by either hepatic dysfunction, can be impaired by pancreatic dysfunction, can be impaired by gastric juice producing dysfunction. The mucosal absorptive phase can be impaired by disease of the mucosa per se, celiac disease, Whipple disease, Crohn's disease, the mucosal disease. And what is impairing the post-mucosal delivery phase? The post-mucosal delivery phase, say suppose the patient is having congestive heart failure or constrictive pericarditis. Yes, you have heard it right. If the patient is having problem in the heart also, then also the patient can have malabsorption. How the patient can have malabsorption if there is problem in the heart? Because of congestive heart failure, or because of constrictive pericarditis. There is increase in venous pressure, the vena cava pressure, the increase in the venous pressure. There is hepatic congestion, there is congestion in the portal circulation, there is congestion in the lymphatics, and the absorption is not occurring properly. Protein is being lost from the gastrointestinal tract because of hepatic congestion, because of portal venous congestion, and because of congestion in the lymphatic, and the patient can have protein losing enteropathy also. So the post mucosal delivery phase, when you think of post mucosal delivery phase, remember that the hepatic congestion, remember the portal congestion, remember the cardiac disorder per se, or any disorder of the lymphatic channel, say lymphoma, the patient is having GI lymphoma. Then also the picture of post-mucosal delivery phase will come, and the patients of GI lymphoma can also have malabsorption. So understanding the pathophysiology of malabsorption will help you clinch the diagnosis. We will help you think when you see the patient of malabsorption, or when you see such patient like that of celiac disease, like that of congestive heart failure, constrictive pericarditis, GI lymphoma, or lymphangiectasia. So these are the main pathophysiology of nutrient processing, and these are the main pathophysiology where the patient can have malabsorption, or the patient can have disorder of absorption. So here we see the next slide. What is happening here? So it is important to know what is diarrhea and what is steatorrhea, because maximum of the patient of disorder of absorption will present to you with diarrhea or steatorrhea, and you have to take detailed history of the diarrhea and the steatorrhea. We will discuss that, but let's see what is diarrhea and what is steatorrhea. So not the normal stool volume. So what you say that the normal stool volume is, normally the patient can have around 3 to 4 passing stool around 3 to 4 times per day, or sometimes it may go up to only once a week. That is also normal. Passing stool only once a week is also normal. Passing 3 to 4 times per day in some patient can be normal. So these are the subjective, but what is the objective definition of diarrhea? The patient is having increase in frequency of stool and change in consistency. Does that mean the patient is having diarrhea? No, that can be normal for the patient. But the objective definition is the normal stool is around less than 200 ml or less than 200 gram in 24 hours. So if the patient is having stool formation less than 200 ml or less than 200 gram per 24 hour, then that is normal. The objective definition of diarrhea is this: if the patient is having more than 200 gram or passing stool more than 200 gram per day or 200 ml per day in volume, then it is said that the patient is having diarrhea. So you ask what is the amount of the stool. If you think that it is more than 200 gram or 200 ml per day, that is per 24 hours, then you say that the patient is having diarrhea. And what is steatorrhea? That is the fatty stool. Steatorrhea is the fatty stool, the fat in the stool. So how you know that the patient is having fatty stool? From history, how you know the patient is having fatty stool? The patient will have large voluminous stool, large bulky stool, and having malodor, foul smelling, large bulky stool floating on the toilet. It's not going away when you flush. It is bulky, it is malodorous. The patient will give history. That will signify the patient is having steatorrhea. But how you quantify steatorrhea? Steatorrhea, when you look at the 72-hour fecal fat collection, so 72 hours stool sample is required, and you check the 72-hour stool sample, the patient is on diet, for fatty diet, on around 100 gram per day. So we restrict diet, or we give fat diet to the patient only around 100 gram, and then we collect stool sample for 72 hours, and we check that the stool fat excretion, if it is more than 7%, then we say that the patient is having steatorrhea. So normally we allow fat for the patient, that is 100 gram fat and we collect stool for 72 hours and we check for the fat in the stool, and if it is more than 7% of the dietary fat, then we say that the patient is having steatorrhea. Very difficult, patients are reluctant to collect their stool, but this is the definition of steatorrhea. This is the definition of steatorrhea. Now let's see what is osmotic diarrhea and what is secretory diarrhea. This is important in history to identify whether you are dealing with osmotic diarrhea or whether you are dealing with secretory diarrhea. This helps us differentiate or delineate the differential diagnosis. So osmotic diarrhea, what happens in osmotic diarrhea is there are osmotically active substance. Osmotically active substance. Let's suppose the osmotically active substance is lactose. So as we know, our body has enzyme which can digest this lactose, but let's suppose the patient is having deficiency of this lactase enzyme which digests this lactose. The patient is having deficiency of lactase enzyme, so there is lactase deficiency. So this lactose will not be digested. There is deficiency of this lactase enzyme. So what happened that this accumulate the carbohydrate, the lactose will accumulate and will go into the gastrointestinal tract, and as it is not digested, this lactose is osmotically active substance. It will draw water along with it into the gastrointestinal tract, and the because it is an osmotically active substance, this lactose is an osmotically active substance, it will draw water inside it and it will cause osmotic diarrhea. So osmotic diarrhea means there is some extra osmotically active substance in the gastrointestinal tract causing osmotic diarrhea. And what in case of secretory diarrhea? In secretory diarrhea, there is no extra osmotically active substance. Instead, there is some substance which is stimulating the gastrointestinal tract to secrete fluid and electrolyte in the gastrointestinal tract. This can be bacterial toxin. The bacterial toxin can stimulate the cells of the gastrointestinal tract. And when these are stimulated by this toxin or these are stimulated by this bile acid, this will cause secretion of the fluid and electrolyte into the gastrointestinal tract, and the patient will have secretory diarrhea. So differentiate osmotic and secretory diarrhea. Osmotic diarrhea, there is osmotically active substance present like that of lactose. In secretory diarrhea, there are some substance which are stimulating the gastrointestinal tract cell to secrete fluid and electrolyte. So there is active fluid secretion by the toxin or by the bile salt. So what will happen? So they are active, in this case osmotically active substance is the lactose. Patient is taking food contain lactose. The patient is having osmotically active substance in the gastrointestinal tract, and the patient is having diarrhea, that is osmotic diarrhea because of fluid entering the GI tract, because lactose is an osmotically active substance. So what we do, if we do fasting, there is no food, there is no lactose, but what happens if there is no food, there is no lactose, then osmotic diarrhea will subside or it will resolve. Osmotic diarrhea will resolve with fasting. Fasting, no food, no lactose, no osmotically active substance in the GI tract, no fluid secretion in the GI tract. So it will resolve with fasting. But what will happen with secretory diarrhea? The endotoxin are always present and is attached with the cells of the gastrointestinal tract. It is stimulating all the time the cells of the gastrointestinal tract, so it will continue during fasting. So remember, the secretory diarrhea will continue during fasting. And what will happen if you check the osmotic gap? If you check the osmotically active substance in stool, it will obviously be more than 50 to 100 because of presence of extra osmotically active substance lactose, and here the osmotic gap will be less than 50 as there is no osmotically active substance. The secretion is because of the enterotoxin or because of the bile acid or some stimulant which is stimulating the gastrointestinal tract to secrete fluid and electrolyte and causing diarrhea. So remember osmotic diarrhea mechanism, remember the secretory diarrhea mechanism. What is the mechanism of osmotic diarrhea and secretory diarrhea? So here you can see how the different macronutrients are absorbed in our body, how the basic physiology of absorption of different nutrient all of you know, but let's sum up quickly. The lipid are digested by gastric and pancreatic lipase. Lipid will be acted upon by gastric and pancreatic lipase, and by bile salt a micelle will be formed. You know all this physiology. It will enter the enterocyte, and here the re-esterification will occur, packing into chylomicron will occur, and will enter the systemic circulation via the lymphatics. So there is first formation of micelles. Micelles is absorbed by the enterocyte, and the enterocyte reassemble this micelle and form chylomicron, which then enter the lymphatics and then go into the systemic circulation. But remember the medium chain triglyceride. The medium chain triglyceride does not form micelles, and it directly enter the blood circulation. Why it is important? Because if the patient is having steatorrhea, fat malabsorption, say because of problem in the bile salt, because of problem in the formation of micelles, then we can treat the patient with medium chain triglyceride. We can treat the patient with medium chain triglyceride because medium chain triglyceride bypass micelle and enter blood directly. There is no help or not taking any help of micelle formation, not taking any help of bile salt to form micelles. It directly enter the systemic circulation. So patient having bile salt or problem in absorption because of bile salt deficiency, say patient is having chronic liver disease, the patient is having problem in the bile duct, common bile duct, sclerosing cholangitis, biliary cholangitis, we can treat the patient with medium chain triglyceride because it bypass micelle formation and enter blood circulation directly. What about the carbohydrate, or how does the carbohydrate is absorbed in our body? Carbohydrate is acted upon by salivary and pancreatic amylase. Carbohydrate digestion starts in the mouth. We have learned it from very small that the carbohydrate digestion starts with salivary amylase. Then it is acted upon by pancreatic amylase. It is absorbed via the brass border cell of the enterocyte, which uptake glucose and galactose via SLC5A. SLC5A help in absorption of glucose plus galactose, and GLUT5 help in absorption of fructose. So remember, GLUT5 help in absorption of fructose in the gastrointestinal tract. SLC5A help in absorption of glucose and galactose, and it is absorbed in it enter the portal circulation via the GLUT2 receptor. So here we must say, suppose this is enterocyte, this is the luminal side of the enterocyte. So here there is SCL and here there is GLUT5. SCL5A will help in absorption of glucose plus galactose. This is GLUT5. GLUT5 will help in absorption of fructose, and on the basolateral membrane side there is GLUT2 receptor, from which both of them will exit the enterocyte and will reach the portal circulation. So how the proteins are being digested? Proteins are again acted by pancreatic enzyme, again acted by pancreatic proteases, pancreatic enzyme, and gastric pepsin as pancreatic protease, which further the chain of reaction trypsinose and trypsin, which help in digestion of the protein, and which finally reaches the portal circulation via absorption with the enterocyte. So these are the basic physiology by which how the protein, the carbohydrate, and the fat are being digested. So now look at the pathology. Look at this pathology. How you see this pathology. So look at this pathology. First is the failure in the luminal preparation. We have discussed the luminal preparation. What is luminal preparation? The first phase or